Let's talk about chest trauma now. Now, we talked about tension pneumothorax, but let's just talk about simple or regular pneumothorax, okay? That can be caused by gunshot. It could be caused by a stab wound, or it can be caused by a rib fracture. So a pneumothorax is common. Generally speaking, a pneumothorax should be treated with a chest tube. Again, that's the safest approach, the safest approach. Now, let me tell you a caveat. If you have a small pneumothorax and the patient is asymptomatic, then you can watch it as long as you keep the patient in the house. In the house. Let me tell you a story. In the first few years of my practice, I put in a Hickman or a central line or something, and the patient had a little itty bitty pneumothorax, asymptomatic, totally fine. And I knew the patient well, reliable patient. I sent the patient home. About 6 hours later, the patient came back to the emergency room, a complete 100% pneumothorax. I put in a chest tube, patient did fine. My late partner said to me, "Mark, what are you doing?" Again, I wasn't being safe. So guys, if you are going to watch a pneumothorax, it's got to be in-house. But generally speaking, for the test, you should treat it with a chest tube. So now I got another question for you. You can get a pneumothorax. Can you get a hemothorax? Can you get a hemothorax? Yes. Test question. The most common blood vessel injured causing a hemothorax is the intercostals. So the most common one is the intercostals for hemothorax. Can you have a pneumohemothorax? Yes. Can you have a hemopneumothorax? Yes. If you have a hemothorax in of itself, when do you operate and when do you sit on the patient? Just observe the patient. Let me give you a basic guideline. If you have a patient come in and they're stable and you stick in a chest tube and you get over 1 liter of blood, you're going to the operating room. If you have a patient come in and they're reasonably stable and you stick in a chest tube and you get 300 cc's of blood, but then every hour afterwards you get 300 cc's of blood, you're going to the operating room. This is not hard and fast rules, but basically this is the rule. Initially, I'm about putting in a chest tube. If you get greater than 1 liter, you're going to the operating room. If you don't get that much initially, but your chest tube drainage is 250, 300 cc's an hour, you're going to the operating room. They're not going to pimp you and try to give you specific numbers. They're just going to give you ballpark. And most importantly, let me ask you this scenario. Let's say a patient came in and I put in a chest tube and I got 500 cc's. And then every hour I was getting 150, maybe 200 cc's an hour. But the patient just didn't look right. What would I do? I'd go to the OR. Why? One reason, safety. No one will ever argue with you going to the OR because of safety. No one will argue with you. They will argue with you if you sat on that patient and the patient crashed. So the rules for hemothorax are basic guidelines. Basic guidelines. All right. That's hemothorax. Next, let's talk about a patient. Let's say a patient lives in Chicago, where I live, and you know there's a lot of gunshot wounds here. And a guy has a shotgun, and it was aiming at the guy's chest and kind of hit the guy's side of his chest. So there's a hole in the guy's chest wall, and you could see his lung. Didn't get his heart or anything, but as you see his lung, got an open hole there. That is called a sucking chest wound. A sucking chest wound. Now, the other name of it, just so you'll know, is sometimes called an open pneumothorax. A sucking chest wound or an open pneumothorax. So, how do you treat that? Well, the way you treat a sucking chest wound or an open pneumothorax is by putting a dressing over the open wound, but you only cover it on 3 sides. You leave the fourth side untaped. You tape it on 3 sides, not the 4th. Why? Because if you taped it on all 4 sides, you would get a tension pneumothorax. So you only tape it on 3 of the 4 sides. Do you need a chest tube? Yes, you need a chest tube. Now let me tell you a story. When I was an intern, I had a guy who had a sucking chest wound. And I immediately put a dressing on it, covered it on 3 sides, not 4 sides, 3 sides. And I knew the guy needed a chest tube. Well, I was thinking, I've already got a hole in the chest, so why put another hole in this guy's chest for the chest tube? So I stuck that chest tube through the sucking chest wound hole, taped it up. I was very proud of myself. The attending came by and said, "Tell me what you did." And I was all set for him to pat me on the back and say, "Boy, this was a great idea." He yelled at me for about 30 minutes. I'll never forget. "Guys, you do not put the chest tube through the open hole. You put it through a separate, clean site." I thought I was doing a great, innovative job. You put the chest tube through a separate site. Okay? All right. Very important. That's a sucking chest wound. Next. You know that when you get a rib fracture, that's common. And you could have multiple rib fractures, and that's common too. But what if you get multiple rib fractures, and when you take a deep breath, the chest wall paradoxically moves in instead of out? Yes, that is a flail chest. A flail chest. You have a section of the chest wall which is not connected anymore. This is a very important concept I'm going to teach you. All right, take a look at my wedding band, okay? If I make one cut in my wedding band, is my ring generally stable or unstable? It's stable. It's got a cut in it, but it's stable. If I make 2 cuts in my wedding band, is my wedding band stable or unstable? It's unstable, meaning a flail chest not only requires multiple rib fractures, but multiple fractures within each rib. That's so important, I'm going to say it again. A flail chest requires not only multiple rib fractures, but multiple fractures within each rib. And guys, the treatment of a flail chest is generally PEEP, positive pressure. There are some people, and you won't get tested on this, in the surgical world who fix these with metal plates. But the most important thing is that you need to intubate these patients and give them PEEP. When I was your age, we used to do sandbags, towel clips. They never worked. So the most important thing is that if a patient has a flail chest and they could die from it, is you have to intubate them with PEEP. Very, very important, all right? A patient who comes in to the emergency room driving their car and has a fractured sternum. I don't mean the xiphoid process at the inferior aspect. I mean the sternum is fractured. Do you call an orthopedic surgeon for a sternal fracture? No. The danger of a sternal fracture is not the fracture itself, it's what's underneath the sternum. What's underneath the sternum? The heart. And what you're worried about is a myocardial contusion. And a myocardial contusion is just like a myocardial infarction, except it's from the outside as opposed to the inside, meaning the coronary arteries. Well, why is this so significant? Well, sometimes you'll see in movies with Chuck Norris or Arnold Schwarzenegger or those kind of movies where they punch someone in the chest and they break their sternum and kill them. Guys, you can't do that. No one is strong enough to break your sternum. So every time you have a sternal fracture, you think of one word: force, tremendous force. Let me give you an example. Have you ever seen someone in a car accident where their steering wheel and steering column are bent because their chest has hit it? And they could have a fractured sternum. But let me ask you a question. If I put you in your car and I said, I'll give you $1 million without any tools if you could bend your steering wheel or bend your steering column, you could do it. So when you have a sternal fracture, you think force. And the significant thing about the force is you got to worry about the heart. So therefore, every time you have a sternal fracture, you have to rule out a myocardial contusion. And how do you do that? Number one, troponins. Number two, serial EKGs. And number three, an echo. Guys, you can't send that patient home without working up that patient. You got to do those three things. Three things. You have to do troponins, echo, and serial EKGs. Because if they develop a significant myocardial contusion and they're at home, they could develop congestive heart failure. They can develop an arrhythmia. Sometimes they can even develop a ventricular aneurysm. That's not a good thing. All right. So just remember, sternal fractures, you think the word force and think about the heart. All right. Now, let's talk patient who comes in with a car accident and all of their guts are in the left chest. That's called a traumatic diaphragmatic rupture. Does it happen on the right side? No. Why? Because the liver's there. It happens on the left side. And the treatment of that is pretty straightforward. Open up the abdomen, pull the bowels back in, and sew up the opening, the tear in the diaphragm. It's not common, but I've seen it a number of times, and you may see it too. All right. Now, let's take another scenario. You're going 60 miles an hour in your car, and you hit a tree, but your airbag goes off. Can anything happen to you? Yes. You can get what is called a deceleration injury of your aorta. A deceleration injury of your aorta. Let me explain. If I am driving in my car and I am holding my coffee cup that has coffee in it, and I suddenly, what will happen to my coffee cup? Nothing. I'm holding on to it. What will happen to my coffee? Go flying. So it's the difference between a fixed structure and a non-fixed structure. Your heart is fixed. Your descending aorta is fixed. Your aortic arch is not fixed. Meaning, when you have a deceleration injury, your aortic arch keeps going. Test question. The most common location for a deceleration aortic injury is distal to the left subclavian artery. The second most common is the aortic root. The first most common is distal to the left subclavian artery. Second most common is the aortic root. Now you might ask yourself, if I took a machete and cut your aorta in half, how could you even survive? You wouldn't. So how do these people come to the emergency room? Well, they come to their emergency room because the adventitia, the aorta, is holding in this tear. It's holding it in. That's why they're alive. The adventitia is holding it in. So how do you make the diagnosis? You get a chest x-ray. A widened mediastinum is a deceleration injury until proven otherwise. That's so important. I'm going to say it again. A widened mediastinum is a deceleration injury until proven otherwise. And if you have a widened mediastinum, you immediately get a CAT scan. Immediately. Guys, if you ever have seen one of these deceleration injury rupture in the emergency room, and I have, and I've opened up the chest, and I am utterly unsuccessful. I can't clamp anything. The patient bleeds out very rapidly. So therefore, a widened mediastinum is a deceleration injury until proven otherwise. Next, you get a patient who comes in who had a car accident and has a pneumothorax. And they also have subcutaneous emphysema. You know what I mean? Rice Krispies in their skin, you know what I mean? Where it's kind of, you could feel the air, subcutaneous emphysema. Put in a chest tube, and you look at the chest x-ray, and your chest tube is perfect, but your lung is not expanded, meaning you've got a pneumothorax, you've got subcutaneous emphysema, you stick a chest tube in, it's perfect location, your chest lung is not expanded. That is a injured bronchus. That is a bronchial injury, and that needs emergent surgery, not the next day, not the next morning, straight away. That is a bronchial injury. All right. Next. You're putting in a central line, subclavian, or internal jugular, or you're operating on the neck. And all of a sudden, you hear this sound, and the patient arrests. Guys, that's an air embolus. It's not common. I've only seen a few in my life. And generally speaking, that patient will die. That is why when you're putting in a central line, you know, you're careful with the ends of the catheters that you don't, you know, let it open to the air and just let air go in, because it's negative pressure. This is something I need to explain to you. In order for you to get a fatal air embolus, you need a lot of air. What do I mean? 50 to 100 cc's of air. Why do I say that to you? Because in the movies, you will watch that when people want to kill someone who has an IV, they'll put a little air in the IV and you'll see bubbles in the IV, and then the patient will die. Guys, that doesn't happen. But you need to know this because patients watch those movies. And if you look at any IV that's in a patient, there'll be some bubbles. And I cannot tell you how many times I have been contacted by a patient saying, Dr. Hill, there's bubbles in my IV, I'm gonna die. Guys, you need a lot of air, 50 to 100 cc's of air as a bolus to kill you with an air embolus. So I just want you to understand that it's not the little bubbles, it's the large amount of air. Finally, talking about the chest, let's say a patient is in a car accident and fractures their femur. Now, you know, because of carpet, remember carpet, that they can go into hypovolemic shock because of their femur being broken, their thigh. But let's say that same patient also develops hypoxia, thrombocytopenia, and petechia. Hypoxia, thrombocytopenia, and petechia. Embolus, fat embolus, a disaster, guys. We don't have a good treatment for fat embolus. It is what we call supportive treatment. Supportive treatment, meaning we intubate the patient, so we give them heparin, we give them steroids. It's a disaster. And the weird thing is, if you ever take blood from a patient who has fat embolus, did you ever look at chicken broth and you see like those droplets of fat within the chicken broth? That's what the blood looks like. It's really remarkable. It's really remarkable. All right.